director of the Kindbridge Research Institute, the only organization in the U.S. with the sole goal of improving telehealth treatment for people experiencing harm from gambling, gaming, and other behavioral addictions. He has worked in the field of gambling disorder research since 2009, and Dr. Smith, also known as Cousin, holds a Ph.D. in psychiatric epidemiology, say that fast 3 times, from the University of Florida, where his Ph.D. mentor was Linda V. Kotler. Give a warm welcome to Dr. Nathan Smith.
All right, it's great to meet people from the Azores. It doesn't happen every day. Can you all hear me okay in the back? Okay. So have you ever had an experience where you could feel your life changing in the moment? Has anybody ever had that kind of experience? You know, as it's happening, you get that kind of rush where you feel your life changing? So, in November 2020, I got a phone call from a person I had never heard of, named Daniel Umfleet. Now, Dan is an American living in the UK, and he was working with a company called Gamban at that time. Has anybody heard of Gamban? All right. So Dan was working with Gamban. It's a company that produces blocking software. You can put it on your phone. So if you want to avoid online gambling, it's actually very commonly used in the UK. So when Dan called me, he didn't want to talk about Gamban. He wanted to talk about his new venture, right? The next idea that he was going to pursue. So his idea was, what if we had a nationwide telehealth company that focused on the mental health of gamblers and gamers in the US, right? Interesting idea. So that idea became Kindbridge, and when I finished my PhD, I became the executive director of the Kindbridge Research Institute. So let's see how the clicker is working. All right, so far so good. So a couple things about this talk. We're going to start very broadly. We're going to start with the 4 crises in mental health in the US. I am a psychiatric epidemiologist, so we have to start there. And we're going to get more specific and more specific, where we're going to end at the end with actual data from the telehealth clinic that was collected in 2021. Just another thing to note. So you have the slides in your book. You have way more slides than you're going to see up here. I took some out. I cut it down a little bit. We wanted you to have all the possible information so you can review it. But if I went over that, I would miss my flight, which is a problem because it's at midnight. So we're not going to do that to you. We're going to go a little quicker. But if you notice that I'm skipping slides, it is on purpose. Okay, so if you can cast your mind back to 2018, before the pandemic began, it's very hard to do because we've been stuck in it what feels like forever, right? But if you cast your mind back, mental health, ooh, that works, nice. Mental health was already in a crisis before COVID. 2018, we were already in a crisis. You all know what I'm talking about. So if you think about healthcare broadly, if you think about physical healthcare, the past 60 years, we've made vast improvements, right? Outcomes are much, much better. If you think about stroke, heart disease, HIV, AIDS, all of these things have improved drastically, right? Morbidity's down, mortality's down. But this is not the case when we think about mental health in the past 60 years, right? So if you're comparing the peak of suicide from 1990 to the peak we have now, we're up 33% now. So everything else on the physical health side, broadly speaking, is going down. On the mental health side, we're going in the wrong direction. And actually, that's not even the worst example. Probably the worst example when we're talking about mental health is thinking about overdoses. Oh, that's interesting. Okay, so I'm not sure what is to be done about that, but you want to take a look at it? I don't know.
What happened?
It's just the slide is cut off there. It's okay. So this is overdoses. Y'all know what it is. So we don't really need the chart. I will explain the chart. 1980, it was pretty low. Now it's 10 times higher, right? So it's essentially almost a straight line up. And so we have 10 times more deaths by OD in the US now than we had in 1980. So what was that, 45 years ago? No, something like that.
That's right.
All right, that's all right. So if we have this going through, I will just tell you what my recollection of what it says is, and or y'all can just read it off your sheets and tell me what it says, and then it'll be like, we'll do some audience participation. Who wants to tell me what the slide says? Is it? Oh. How did I practice it so many times and not notice that? That's interesting. All right, so you get the idea. Talking about mental health care and the mental health crisis, we're up 10x. So if you add those suicide, death from suicide, drug overdoses, alcohol, put it all together, what has been called deaths of despair, I have a lot of feelings about these different ways of thinking about this, but the overall point, life expectancy dropped 1.5 years in 2020. Not only that, there's been a durable drop in life expectancy. Over a 5-year period, life expectancy has dropped in the US. That hasn't happened in the US since 1918. Now in 1918, we had 2 crises going on. Who wants to tell me what the 2 crises were? I teach undergrad, so I just yell questions at you. World War I, yes. So I also have otosclerosis, so I can't actually hear you. So I just pretend like you get it right anyway. So just so you know that it doesn't matter. When we do questions at the end, we're gonna need the mics. None of this like yelling out thing, it's not gonna work. So 1 is World War I, that's correct. 2, just the flu, yes, that's exactly right. The Great Flu. So it was a war and a flu. And which had more deaths? The flu, yes, exactly right. The flu killed more people than World War I. So that was the last time, 100 years ago was the last time we had a durable drop in life expectancy in the US. So when we think about harm, it affects minoritized groups worse than everybody else. When you look across the whole United States, again, I'm an epidemiologist, I do this for fun, I look across the data for the whole US, it's always affecting minoritized groups, more so African Americans, Latinx folks, LGBTQIA plus folks, and that's something that we see no matter what you're looking at, you're going to see that pattern, and so that's something that we're thinking about, and as we create telehealth, where there are more opportunities to get folks from all over the country working, it's something that we think about. Okay, so that was crisis 1. Let's go to crisis 2. I'm not going to belabor the point of what COVID-19 did to mental health. Y'all are familiar with it. Other folks have talked about it. But just in brief, depression is up, anxiety is up, social disconnectedness is up, substance misuse is up. Everything bad is up, right? So you could think of that as crisis 2. So that's a crisis on a crisis for those of you keeping track. So crisis 3, we better go back and talk about that. 577,000. So this is the number of licensed mental health professionals in the US. Seems like a lot, right? It kind of seems like a lot. I mean, I wouldn't want to buy them lunch, but when you think about how many folks that actually is, I teach undergrads. So if I say something that I think is funny, I'm just going to keep going. So y'all can laugh or not, it doesn't make a difference to me. I'm just going to keep going. So if you think about that as 600,000 people, right? So if all of those people are really busy, say you have 25 people on your roster, and then the next week you're doing another 25 people, you're going every other, then one person is seeing 50, right? So if you do a little math, and that's really max capacity, 50 for one every other week, that's a pretty heavy load. So if you do 50 times 600,000, for our mathematicians in the audience, that's 30 million. Again, sounds like a lot of people. So this is max capacity of the US mental health care system for this type of treatment is 30 million. So seems like a lot, but then when you think about the amount of folks that actually need care, so you have 330 million folks, right, in the US, and now we're talking about 25 to 35% of those folks. We're talking about 100 million or 110 million people, right? So our max capacity, everybody working as hard as they can, 30 million. But what's our need? It's 100 million, 110 million. So there's 70 to 80 million people that can't get care in a best case scenario, right? So that's crisis 3, right? A crisis on a crisis on a crisis. I didn't start my timer, which makes me nervous because I tend to just say whatever I want. So I just got to keep an eye on that. If I start to wander away over time, somebody just wave at me, it'll be fine. Okay, so what happens when you have 70 to 80 million people who can't get the treatment they need? Well, if you go in and try and get treatment, you might have a wait time of 25 days, in some places 90 days. This is for psychiatric care. In my home state of Massachusetts, where they keep really good data, if you go into an emergency room, you would have to wait about, they said 53 hours, right? So a couple days, more than a couple days to get a psych eval in Massachusetts. This is particularly bad news because Massachusetts has a lot of psychiatrists and psychologists per capita, right? We have a very high number of psychologists and psychiatrists per capita. So if it's bad in Massachusetts, which it is, you know, somebody comes in crisis to the emergency room, nothing else that they can think of to do, go to the ER. That's the right thing to do, right? That's what we tell people. And then they get there and it's 2 days, 2.5 days. And this is in the good case where Massachusetts, we got folks there. Other places where they're not actually keeping track necessarily, we would assume would be potentially much worse, right? So finally, uninsured folks. So 25% of Latinx folks, again, something where harm falls disproportionately on minoritized groups. And uninsured, being uninsured, of course, makes a lot of things with healthcare difficult. And so this is, again, a topic that has been talked about a lot. Y'all are very familiar, I would guess, with insurance and uninsurance and what that means. So we'll do that. I guess if that's the fourth crisis, then that's a crisis on a crisis on a crisis on a crisis. Okay, good. So even when someone has insurance, insurance companies are not always fun to work with, right? This is probably not news to anybody in this room. So we, running a telehealth clinic, particularly at the beginning, is doing a lot of work with insurance companies, which is, you know, doing things like saying, okay, we're a telehealth company, we don't have an office, right? Does anybody have a fax machine? No. Why would we have a fax machine if we don't have an office, right? So everything is difficult, everything is slow. So incredibly slow, archaic patient routing systems, that's a very nice way of saying that. Patient routing systems where the patient enters and they come out, you know, they run into the Minotaur at some points and then they come out, you know, who knows where, right? Exclusions, is there something new? Might it work? I'm sorry, we don't cover that, right? You're on the platinum plan. I'm on the tin plan. What the heck is going on with these plans, right? Nobody even knows what covers what. So this is something we've been running into a lot, exclusions everywhere. And then low reimbursement rates, another thing unfortunately I probably don't have to tell this group about. The reimbursement rates for a lot of companies, astonishingly low. And this is a problem because, you know, you go get a master's degree and you work really hard and you learn a lot of skills and you go through the trainings and you come to things like this and get CEUs. And then you do an hour with somebody, tremendously difficult work, and it's, well, we reimburse at $60, $65, right? Doesn't make sense. Again, I think maybe y'all understand this. And I guess the worst thing is you gotta wait to get your $60, right? And this is something we've been learning the hard way. They're tremendously slow to pay. So a couple times we've had questions like, is this insurance company actually taking our patients? Is this working? So we call them to say, is this working? And they say, well, our reimbursement process takes 6 months. So just wait 6 months, and if you get a check, it's working, right? It's so helpful, right? Tremendously helpful. So this is actually something we actually don't know. There are a couple insurance companies we don't know if what we're doing is working because we haven't been reimbursed yet. So even if you have insurance, it can be a hassle. So there we go. Okay, so all of the crises, y'all are familiar with the crises, y'all are familiar with the background. So I guess that's the bad news. Now the good news is there's a lot of things happening technologically, things like alternative insurance companies, technologies, new approaches, employee benefits. People are being creative, they're trying to solve the problem. The problem was well known, it's affecting a lot of people, so there's folks out there trying to solve it. So you probably are familiar with some of these companies. Just for my own benefit, I won't make you say who, but has anybody worked with any of these companies? Talkspace, BetterHelp, Ginger? Yeah, you can just nod your head. You don't have to put a hand up. Like, you don't have to, yeah. If your boss is here, you don't have to say anything. Like, it's fine. Totally fine. So this was Tele 1.0, right? This was the first attempt at this kind of like massive tele. And it worked really well in some ways, So the technological problems were well solved in Tele 1.0. And then in other ways, not so well. And again, this varies company to company. We're not going to talk about anyone in particular up here from the stage where we're being recorded. But, you know, we can have other conversations later if you all are interested. Oh, there we go. Okay, so the technological problems were pretty well solved, but there were other problems that came up. So a lack of engagement, right? So you can connect, but will you? Do you want to? Do you want to go back to see the person you were seeing before, right? There's a lot of problems with engagement, and this has been a problem across gambling disorder research. I mean, I started in 2009 and was reading studies, I think by Wendy Slutsky from maybe 2007. And after reading that study, I said, man, this lack of engagement is a huge problem. That was like within a few months of starting in 2009. And we are now, I don't want to think about how much further along, some number of years later, and this is still something that we're dealing with every day, all the time, right? The big problems stay the big problems, and which is why we need to start thinking, what are the big solutions, right? What are the big disruptive things that can be done? And that's something we try and think about. So, lack of quality. I mean, there's a lot of reasons for lack of quality. I mean, you all know that there are some treatment providers, you don't have to, do not name names, do not point at anyone. There are some treatment providers where maybe the care is not as good as it could be. I see you looking around. Stop looking around. Just keep your head straight. There can be a lack of quality, right? We'll just leave it at that. And a lack of accountability too, right? It can be very hard to measure outcomes, and the outcomes we measure aren't necessarily the things that need to be measured. So some of the telehealth 1.0 companies, we're not going to name names, are measuring outcomes with people who continue to pay their bill, right? It's $99 a month to belong to our program. If you keep on paying your $99 a month, that's a good outcome from some perspectives, right? But is that a good mental health outcome? Is it a good outcome for the individuals in care? Is it a good outcome for the treatment providers? Are they making progress with folks? Are they feeling like the work they're doing is good and important, right? So thinking about the outcomes, what are the measures, right? What do we need to be measuring? So some of the ways we've thought about addressing these problems: person-centered online care, coordinated connected care, measurements and value-based care. These are things we'll talk about a little bit. So enter Kindbridge, okay. So I get that call from Dan Umfleet. He's putting together a group. He wants to bring together technology, which luckily he has expertise in, so he brought himself and the other founders. Clinical expertise, Mark Lefkowitz, Lori Rugel, a number of other folks that y'all might be familiar with, brought the clinical expertise, and then the research expertise. And that's one of the reasons I got that phone call, was adding me to the team of folks who work on the research side, along with Leah Nauer, Tim Fong, Jeremiah Weinstock, a bunch of folks y'all might be familiar with. Stephanie Diaz-Morel, focusing on the video game side. So the idea was to bring folks with these different pieces of expertise together to put together this telehealth treatment program that could be nationwide. So another thing I do not have to talk too much about, because y'all are going to be familiar with, some of the problem gambling treatment infrastructure in the US can be a little hit or miss, right? Depends on where you are and what's going on. So we have a lot of sort of fun things. People, I don't know if you all get this, but whenever I tell people there are 28 helplines, they always really enjoy that. We have 2 in my home state of Massachusetts, yeah. If 1 is good, 2 is better, right? So we got some chaos coming from the helpline, sure, that's well known. The data, so there are problems with the data. So every state is collecting data. All of these helplines are collecting data. They're not necessarily collecting the same thing. It's not something you can put together. It's not shareable. It can't be aggregated very easily. It takes a tremendous amount of work to do the aggregation. It's not something that is happening in real time, right? Jeff Murat is nodding his head. Yeah, Jeff knows what I'm talking about. So because we can't aggregate it in real time, then things can be happening that we can't see, right? And that's not very useful. So there's a few other bits here. I guess the last one that I'll point out, just the general lack of awareness, right? How many times do you meet somebody and tell them that you work in gambling disorder, and they go, oh, is that like, what's that like an addiction, or is it like, right? So see, I don't know in Nevada, maybe that's the wrong crowd for that, but Where I live in Boston, it's kind of a common, once you say what you're doing, you have to say a lot more so people know what it is you're actually doing, right? So there still is this pervasive lack of awareness, which doesn't really make any sense given we've been in the DSM since 1980, right? That's before many folks here, including myself, were born, right? Yeah, okay. So we've been in the DSM. I realize we moved where we were in the DSM, but we've been in the DSM since 1980. We've been in the DSM for the same amount of time as PTSD, right? Okay, all right. So right, I'm a psych epi, so I'm gonna wander and say things like that. You just have to bear with me. But I assure you it's true. You can go to your DSM-3 and look it up. Okay, I better check my time, because God only knows. All right, good. So, one of the things we're thinking about is access. This is something that has been talked about a lot. Carol O'Hare said earlier, meet them where they are, right? Meet them where they are. Now, that's something we think about a lot. So we have this problem with engagement and with access. How do you meet somebody where they are? So one way to do that is to work with big insurance companies. It's a huge hassle, but we're doing it anyway. So we have relationships now with these companies here, Blue Cross Blue Shield, some others. Another way you meet people where they are, employee benefits programs, right? So if you have a job, you can have access to resources. If your employee benefits program works with Kindbridge or anybody else who does this for gambling. So this includes not only treatment, but also education, right? Psychoeducation, groups, trainings, videos, anything you can think of is something that you can do for employee benefits. Right, and this is another way to sort of get out from where we are to get into where people are to meet them where they are. Something we're thinking about. How do you get more people engaged? Casino sportsbook companies, so there are 2 that we're working with now. We're open to working with more. Either for the staff, the employees of the company, we could work with them to help take care of the employees, again, with a variety of services, or directly with players, right? And I'll actually show you an example of how that's possible in a couple slides. But we're open to meeting people where they are on the player side and on the employee side. And then finally on this slide, just a little list of all of the various things that can be done. Psychoeducation, mindfulness, coaches, peer support, mental health therapists, therapist-led groups. All of these things that y'all are familiar with can be done right in the app. Oh, this is my favorite. Okay, so this is the big blue button. It says help now. I love the big blue button. I'm very excited about the big blue button. So you can put this, we have the technology, so you can put this on any website, you can put it in any app, and when you think about it happening at scale, when you push the big blue button, in about 90 seconds, first off, you'll be chatting with somebody, a real person in real time chatting with you. And then in less than 10 minutes, you can be face-to-face via your phone or your screen, whatever it is, with a counselor who is licensed in your state. And this is 24/7, 365 and a quarter, right? It's the whole year. So this is one of the advantages of being in America, right, which is a very long country. So we've got folks in Hawaii, we've got folks in Maine, and they can cover all 24 hours without having to have any really sort of bizarre shifts, right? Someone in Ohio can cover Maine in the evening and it's 2 in the morning. And why is this important? Again, something y'all are familiar with. If someone's in crisis and they reach out for help, how long do you have to help them? Is it an hour? Is it 15 minutes? It's probably not 3 days, right? You have a brief window. That window is brief because maybe they think, well, I could move some money from here to there, and then, well, maybe I don't really need the help this time, right? And how many times have you heard stories of folks who called a helpline or reached out for help in some other way, and then decided, I don't really need it. And then, then 2 years pass, 5 years pass, 7 years pass. And many times, and this is good, they end up getting the help they need eventually. But what happened in that 5 years? What happened in that 7 years? What was lost there that could have been saved if there was something where you could be talking to a licensed clinician face-to-face in less than 10 minutes? Now again, this is something that has to happen at scale. You need a workforce that's large enough across the country to cover all of the hours. So Again, something that, there are a number of things here that are technically possible, that we have the technical and legal capacity for, that we have most of the infrastructure built out for that we are not yet doing. This is one of those things. I love the big blue button. I think at some point somebody's going to see the value in it and want to partner on bringing it into their group. I don't know if it's going to be a company or a state or a university or who it's going to be, but I think it's going to happen, and I'm going to be excited about it. Okay, so one more way to engage. Student engagement. This comes directly from a pitch we made to a college, to a small college. So when we think about engagement, right, there has to be ways where you meet people where they are. So this is where we actually go out to a university, do a 2-day in-person mental health event, provide speakers, screenings, workshops, and then throughout the year, more speakers, trying to build engagement and community awareness around this. So this was for a university, but you could do it at a company or any other place similar to that. And so the idea would be, after the in-person, you have the app-based, which builds the connection and keeps the connection the full year. And again, it's 24/7, 365 and a quarter. All of these things are available. Okay, everybody awake? I have a laser pointer. I will point it at you if you fall asleep. I am not afraid. I teach undergrads. I am not afraid of you. All right, I'm watching you. Thank you. Okay, so predictors of treatment response. So this is things that I'm particularly interested in, being the scientist in the field, at least in this company. Actually, whenever they have a question, they come to me. So I better be interested in all these. So what are the standard measurements across the continuum of care? This is something we think about a lot. We don't just want to measure a number of symptoms or an amount of harm. We want to measure what's your mental health like generally, what's your physical health like generally, what's your social health like generally, are you socially connected, what's your environment like, right? All of these things. So when the World Health Organization thinks about health, they have many different categories. And yet most of the time when we do measurement, we're just measuring a number of symptoms, right? You've got the DSM, you had 9 symptoms and now you have 7, that's good. So we are measuring that, that's very important, and in addition, we're measuring a lot of other things because we believe that the folks who come and work with the counselors at Kindbridge are going to get better, see improvements in their life across a number of different ways, right? So that's one of the things we're thinking about. So data-driven solutions, if enough people are using the system, then we can answer a lot of complicated questions with the data. We're going to talk a little bit more about that in a minute. Training curriculum, informing providers. So informing providers, taking care of providers is a big part of the model, right? So providers do better work when they're paid more. They're not worrying about insurance. So, we worry about the insurance, we worry about the legal. We pay as much as, we pay pretty well, I will say that. I'll leave the business stuff to the business folks. But the idea being that a clinician who is happy and has some extra time can take more patients and do better work and provide better outcomes. And that's the goal. Because what we're looking for is high quality outcomes. So this is something we're thinking about all the time. How do we make the clinicians' lives better? How do we make them easier? And another thing we do is work with the data, and we'll talk about that when we get to the data. Another thing we think about. And then the ability to make systematic changes quickly and efficiently. So we're telehealth, so we're all over the place, but we can all meet together. And because we're using data and we're seeing it in real time, we can say, hey, we see this thing happening. Think about that. Now, of course, we don't want to overload folks because that makes no sense. But if we see something important enough that it would make a large difference, then we can send out some sort of APB to everyone so they know this is something we're seeing. We hope that it improves your practice. And then you can write back and say, why are you following me? Or whatever you want to say, because the relationship is open in that way. But this is something that we're thinking about too, is improving care in this way. So all of this takes technology, and not all of the technology exists exactly, right? Which has turned out to be kind of a problem. But most of the technology exists most of the time, and so we're making progress with that. Just a couple things. So a measurement feedback system. So we have a way where we can push questions directly to the patients, to their cell phones or to their email, and that links up with the EMR, right? So that, and then it can be built out by disorder. So somebody comes in with a gambling disorder, that's what they're presenting with. We can push the button that says send them the gambling disorder questionnaires, and it sends all of the basic things you would think. And because it's gambling disorder, we're also going to check for impulse control, we're going to check for depression, we're going to check for anxiety, we're going to check for PTSD, or whatever the particular cocktail is for that. And then that will be followed up. So we're not going to follow up that whole battery, right? But we follow up with various pieces of that as time progresses. So you can see all the data very clearly. So of course you begin at the beginning before their first session, but we can also check things like, how do you feel about your therapist, right? How is that interaction? How is that therapeutic connection that's so important? You can check that after the first time the patient and the clinician meet. And so you can kind of head off problems. Hopefully you can head off problems before they can begin. So that's using the measurement feedback system. And then on-call is the EMR we're using. It's very slim. You can add a lot of technological pieces on top of that. So the technology is a big part of all of this, and it's not entirely there, which means, on the scientific side, we have to do a lot of work to make it work, but it's working. Yeah, it's working, but we're making it better. Okay, so time to talk about data. Very briefly, there are no charts, I promise. There are no charts, there is no math. We're just going to talk about data briefly as a process. So the patients and clients come in from all of the different sources by which they come in. They produce data. That's the little Rutgers symbol, because we're working with Rutgers and setting up some of these ways of thinking about how this data should be collected and what should be done with it. It moves over to the Scientific Advisory Board for improvement opportunities. And so this is informing not only us, but hopefully other folks who want to be telling other people, putting it out publicly, which is why we're partnering with the universities, because the universities are going to publish it in peer-reviewed studies. So it's going out, so people are learning from what we're doing with the data that's coming in. And then as that is happening, it's feeding back into decision-making. And the goal is that we should be getting better all the time, right? We're using the data to get better all the time. That's the idea. Right, that's the goal. Okay, so what happens if this is successful? Increasing access to care, eliminating treatment disparities, reducing hospitalizations, all of these things are possible as we go along. Okay, so the question now, what have we learned so far? So we're looking now, just checking my time to make sure I'm not keeping anybody hostage. I'm not yet, but we may get to that point. What have we learned so far? So the total population in 2021, 40 patients, 65% men, 35% women, so about a 2-to-1 split there. Highest volume state, Tennessee. I have no idea why that is. It says on my badge, Tennessee, Chattanooga, Tennessee, which is where the company is settled, but we're virtual. None of us live in Chattanooga, Tennessee. It's just where they decided to set it up. So I thought that was exciting to be like, oh yeah, Chattanooga, Tennessee. Literally nobody who works for this company is in Chattanooga, Tennessee. So total number of gamblers seen 12. So of the 40 people come in, only 12 gamblers. So we're focusing on gamblers, and we're getting 3 times more people who are not gamblers. So in that way, we could be doing better. We would like to be seeing more gamblers. We would like to have partners who are helping us see more gamblers. That would be great. But we are seeing folks, so that's good. We're going to continue doing that. One thing to look at here, the therapist-patient connection. So we've got this question about how do we make things better for the patients? How do we make things better for the therapists, right? So how do you choose which therapist should be with which patient? Well, if you're doing this at scale and you have data, you can optimize that, right? You can make it so the people that you're seeing have been picked because you have been very successful with people like them in the past, right? This is something that is possible if you have the data beforehand. And as I've pointed out, we have the ability to start to look at this data and say, how do we make the best possible connection there? So this is not the actual connection. This is just as a way of thinking, well, what kind of effect size are we looking at, right? How big is the difference when you look at some of this data? So if you start with female therapists and female patient pairs, the average was 5.25 sessions. The other female patient pairs, right. So male therapist, female patient pairs, 3.5 sessions. So just that by itself you're looking at an increase of, I don't know, what is that, 1.75? 1.75, which is half of 3.5, right? So that's 50%? Yeah, this is live epidemiology, happening live and in person. Epidemiology on the fly. Okay, so, and you see then male patients, the matched male therapist, male patients had 4 more sessions, right? So more than double the number of sessions. Now, this is sort of a very crass way of looking at this, but the idea is, can you make changes that improve the number of sessions that people go to? Because it's very hard to help folks when they don't come to their sessions, right? So the question is, can we improve those links and get more people to go to more sessions? And the answer, at least in the early data, and keeping in mind this is based on 40 people, so we're not going to be publishing this, this is just something to be thinking about. So there are a lot of ways to make this better, and that's really where we're starting at. Okay, so what have we learned so far? Part 2. About 20% of the folks were rural. We're expecting that we're going to be seeing a lot of rural folks as we spread out. I mean, it just makes sense, right? If you live 100 miles from a clinician, which, you know, the US, I'm not sure if you've looked at it, it's quite large. There's a lot of people who live 100 miles from a clinician. That's not an uncommon thing. So we are thinking that as we expand, we're going to start seeing more folks where it's easier to do telehealth, which also causes some problems, which we'll look at in just a minute. So median age of clients, 36. High levels of stress, anxiety, depression, substance use, no surprises there. Moderate levels of medication folks are using. And then in the first go of how are we doing in Kindbridge, how are we doing? 88% of those polled post-treatment agreed the therapists were helpful, 12% said that they were not happy. Now my hope is that this is the baseline, and as we do all the things we are trying to do to get better, this number gets better. It's also my hope because it's a part of my job, and so if we don't, that's going to be a problem for me, and I will not be attending your future meetings. But my hope is that 88% is the baseline, and that we're going up from there. I don't actually know what the average is across the country. I don't know if anybody knows. I don't know if it's something that is measured and spread out publicly, but it's interesting, right? So this is the baseline. So just zooming in quickly on the gambling folks, we had 12 of them. 5 came for sports betting as the main form, 3 slots, 2 table games, and 1 person horses. And then of the gaming, so y'all learned a lot about gaming today, so we don't have to do much explaining here. Of the gaming population seen, RPGs were the most frequent. Massively multiplayer online role-playing games, MMORPGs. I bet you didn't think you were going to have 2 different presenters say MMORPGs in a session, but it happened today, right? Ted, right? Yeah. Ted knows. So these are games, well, actually Ted gave, I'm not going to belabor the point, Ted gave examples of this in his talk. And then in-game purchases, we're seeing as high as $400 a month for in-game purchases. So a lot of significant funds being spent, even though gaming, often we don't measure the money being spent at all, we measure time and other outcomes, but maybe we need to think more about what it's like to measure the money being spent. Okay, and so the bad news, we've also learned some things are difficult. Not everyone has good access to internet. This is particularly true in rural areas, which our idea was we were going to be particularly useful in rural areas. And that is true for folks who have high quality broadband care, so they can get access to care. But we have found this to be a problem. So not everyone has access to technology. Not everyone knows how to use the technology if they do have access. So there are technological and internet broadband-based problems as well. We never thought that tele was going to be a panacea, but it can be something that offers some value. So of course, not everyone has access to funds to pay for services. Some folks are luckily in states where they can actually have access to funds. Many people are not. Right, so still plenty of issues that need addressing. Okay, so where are we trying to land by 2024? I will check to make sure I'm not. Yes, all right. Oh, there's a person with a sign. Thank you very much. I appreciate that. Okay, so I think this is the last slide, so we're doing fine. Well, I don't know. We're going to find out in the comments, right? But, I'm going to stay on time. Whether we're doing fine or not, we'll see later. So if you cast your mind back 30 minutes ago when we were talking about 70 to 80 million people who could not get the treatment they needed, no matter what, because we didn't have the folks to do the care, well, how do you solve a problem like that, right? Well, you could triple the number of folks who are treatment providers. That would be one sort of very direct way. I don't know how you do that. I don't know if it's possible. But that would be one way to solve the problem. It's not a very good way. Well, in that it's going to be pretty tough. So another way you might do that, and this is something that we're working on now, the goal is to be doing more of this by 2024. If you think about, it's kind of an upside down pyramid, right? So we want people to be landing where they need to land in the pyramid to get the amount of care they need, and then bump down a level as they need more care, right? That would be the idea of this. So something like communities. If you're on a college campus, you build a community that is supportive to mental health care, that knows about gambling disorder, knows about gambling risk factors, all of those things. Well, that's going to be beneficial for some folks. Now, if somebody needs more support, they go down. Skills-based learning groups, right? And this can be almost literally anything, right? Based on books, based on videos. They can be peer-led, they can be facilitated. So all of these, and there are tons of things that folks can learn in skills-based learning groups. So then you need more support, you bump down. Therapist-led groups, you all are familiar with therapist-led groups. You bump down. Coaching. Now some people will not go to therapy, but will go to coaching. Anybody know any of these people? Do not raise your hand again, thank you. Yeah, so coaching, right. So we offer that. It's similar to therapy in that in some cases it's exactly the same, but in other cases, coaching is a legitimate thing, right? It is its own thing. And sometimes people are doing coaching and sometimes people are doing coaching, right? So whatever you need, we're not here to judge. If you need coaching, we'll get you some coaching, right? Whatever it takes. So coaching, that was a long one on that one. Therapy, finally, everyone knows what therapy is. That's the final stage, right? So the idea would be we have 70 to 80 million people who can't get the care they need. But if you could sort properly, and you could sort efficiently, and you could sort early, that's very important. Don't wait until you need therapy. But when you need a little bit of support, and if you had some way of finding out that folks needed a little bit of support, all right, so maybe a skills-based learning group would help you. And then you're experiencing some problems, you get the support level that you need, and then you stop experiencing those problems, right? That would be good. And so instead of waiting until everybody is in crisis all the time, you get the proper amount of intervention to the right person. Now this is essentially, if you had enough data, this is a relatively straightforward matching problem, right? So you would need a lot of data and a lot of people, and you would need all the systems built out. But the matching is relatively direct once you had data at scale, right? So this is another way that we're thinking. And then, of course, I should say intensive outpatient and inpatient at the bottom. Those are in red. We're not going to do that. We haven't figured out yet how to have people check into their phone to stay with us for a week or a month. But when we figure that out, we'll let you know. We're probably never going to be doing that. That's always going to need to be done where it's done today, right? But we'd like to stop folks from getting there, right, by interrupting that process. Okay, so I feel like I've gotten pretty close to the time. Yeah, everybody's nodding, that's good. Yeah, people are not, it's fine, people are nodding. And congratulations to everyone, you made it through. No one fell asleep. That's not true. I know which of you fell asleep. All right, final note, and then we'll go to questions. I wrote this down, so I would say it right. We'll see. Mental health is going through a revolutionary transformation right now, and together we can all take advantage of it to create more access points, less expensive care, and better outcomes for everyone. Hey, we read it. That was good. Thank you. And so, if you want to work with us in any way, we want to work with you. We want to speak with you. We want to work with you. If you are here, then we want to work with you, right, by definition. So you can contact me, although I can't get you a job. So maybe you should contact Dan, because he can actually get you a job. But contact me if you feel like it. It'll be fun. Please do reach out to us. And I guess the one final note, it's never too late to go over your time. One final note. We are getting a lot of contact from folks outside of gambling and gaming. This was created for gambling and gaming. We are getting a lot of contact from folks outside of gambling and gaming who are interested in using some of the methods, some of the technology that's being built. And we are happy to be working with those folks, but we'd be really happy to be working with y'all because that's why we designed this thing. So I got a call last week for someone who wants to do a sleep study. We're going to do a sleep study. They showed up with cash. They want to do a sleep study. We're doing a sleep study. However, we designed this for gambling and gaming, and that's really who it's intended for, what we'd like to do. But, we're going to work with whoever shows up and sees the value in what's being done. So I guess at that, I will open for questions.